Welcome everybody. This is our APSA breakout session to patch or not to patch vascular reconstruction in peripheral ECMO in children. Thank you so much to APSA and to the organizers of this session for the opportunity to have this session today. I would like to also thank the APSA Critical Care Committee, especially Adam Vogel, for his leadership and guidance, as well as the Society for Vascular Surgery, from whom we have a couple members here today. I'm Shunpei Okochi, Surgical Director of ECMO at Mount Sinai Hospital in New York City. I'd like to introduce the rest of our panel here today. So up with me is our co-session lead, the amazing Dr. Natalie Drucker from UT Houston. Dr. Drucker is a pediatric surgeon with a background in critical care and a specific interest in vascular surgery and ECMO. We're also very fortunate to have with us Dr. Don Coleman, who joins us from Duke University. Dr. Coleman is one of the co-leads of the APSA SVS task force and is the chief of vascular surgery at Duke. We also have with us Dr. John White from Advocate Lutheran Children's Hospital in Chicago. Dr. White is also a co-lead for the APSA SVS task force, and he has a long-standing commitment to helping care for vascular problems in neonates and children. Last but certainly not least, we have Dr. David Rothstein from Seattle. Dr. Rothstein is also a co-lead for the APSA SVS task force and is an expert in the field of vascular reconstruction for pediatric ECMO patients. So, our objective here today is to better understand vascular challenges that we face as surgeons taking care of our pediatric ECMO patients. And once we started to put this presentation together, we were thinking and we realized that we could talk about this for days. And so today's session is going to really focus on VA ECMO. We're going to leave VV ECMO for another day. And to break this down further, we'll first start with a brief review of carotid cannulation and decannulation, followed by femoral cannulation and decannulation, and finally surveillance after decannulation. Our hope is to have this be an interactive session, so that's all of you. And so please participate in the polls. Feel free to ask questions along the way. If anything doesn't make sense, if you have a comment, if you want to throw something out there, just feel free to chime in. As many of you in the audience know, unlike adolescents and adults that have large femoral vessels, neonates and small children that require VA ECMO often require cannulation through the common carotid artery and the internal jugular vein. Two common techniques for cannulation include what I will be referring to as the vessel ligation technique and the vessel sparing technique. In the ligation technique, a cut down is performed over the right neck, exposing the common carotid and the internal jugular vein. Both vessels are then encircled and tied off in the cephalad direction. The vessels are then entered below the ties and cannulas are secured with circumferential ties. With a vessel sparing technique, a 5-0 or 6-0 proline is often used to create a purse string around the arteriotomy and venotomy sites. These are then secured to the cannula with a Rommel tourniquet. Here's our first audience poll. For those members of the audience who cannulate for cervical VA ECMO, what is your choice of technique? Let's get a show of hands. So how many people routinely ligate the vessels? Oh, that's a lot of people. Okay. How many routinely spare the vessels? Not many. Okay. Does anyone here do anything different other than those two? Okay. As do I. And I think that is very patient specific. I'd also like to poll our experts. Dr. Rothstein, do you have a preferred technique?
I do number one. I'd like to get better at number two.
Okay. I usually personally do vessel ligation because I believe that with the large cannulas that we use relative to the size of the vessels, they're essentially lumen occlusive. When you do an ultrasound on them, which I sometimes do after doing a vessel sparing technique, I try to take a look to see if there's anything really getting past it. There's very little antegrade flow that makes it past the cannulas. So my argument is whether I ligate them or whether I'm doing a Rommel tourniquet, probably doesn't make too much of a difference. These kids also collateralize very quickly. And so when you look at ultrasound studies of them 2 to 3 days after cannulation, there's a study that is actually in publication right now looking at ultrasound studies. The collaterals develop very, very rapidly. Given that the ligation technique is significantly easier to do in a very stressful situation, which ECMO, as all of you guys know, is, I try to simplify my cannulations by doing this technique for the most part.
There's an argument to not so much the preservation of flow, but the ease of closure and preservation long term. I think that's one of the arguments that
For sure, that's definitely one of the arguments. So ease of closure, I think it is easier if you have a Ramel tourniquet, but also by the time you're closing, those kids are much better, right? My argument would be that when the kids are sickest, you want to get them on fastest, and you want to do the technique that you do well, that you do often, and you can do in the middle of the night at 3 in the morning. By the time that you're ready to close, sometimes I take these kids to the operating room and we can do a nice closure on them. And we have all the time in the world. They're down on their pressors. They're not on crazy vent settings. And so I think closure is definitely one argument to do the Ramel technique. But for me, I think the time of cannulation is really where I'm feeling the stress. Brian Gray is nodding along. I'd like to take a minute here to talk about some alternative techniques that we have. These have not gained as much traction as our traditional neck cannulation, but may be appropriate for the select cohort. And so I just wanted to bring it up here. I don't know how many people have done these techniques and may have more experience than I have. I have had some exposure to these from my time at Columbia. So the first technique is the use of an arterial chimney graft. We specifically used it at Columbia in the setting of our subclavian and axillary artery cannulations. The technique was first reported in the 1990s as a method of vessel-sparing cannulation in patients with vessels that were too small to fit a cannula by traditional cannulation techniques. Specifically, the chimney graft involved an enticide anastomosis of a synthetic graft onto which the cannula tip was inserted. We typically use the 6-Zoproline to do this. At the time of decannulation, the graft was left attached to the vessel and closed at the level of the vessel as flat as you possibly could with a proline suture to avoid vessel stricture or stenosis. Challenges of this technique included the fact that it was time consuming at the time of cannulation when your heart rate is probably higher than the patient's. It could easily kink or twist when the cannula was inserted. The weight of the cannulas was often enough to cause a twist. I'd like to also turn to our expert panel at this point and see if anyone here has experience using these chimney grafts and what tips or tricks you may have to successful use of these.
I think that it's an excellent technique, and I think one of the tricks is figuring out where the way your cannula is going to lay, because it's the angle at which you cut the graft that determines where the graft is going to lay. So if you cut it perpendicularly, I mean, if you don't cut it at all, it's going to just jut up perpendicularly. Clearly, it will kink, so that if you want to lay your cannulas down, you have to cut the graft at a fairly steep angle, and so to the vessel, so that there's a smooth transition into the vessel. It keeps it from pulling out, because I don't fear kinking of the graft as much as I worry about ripping off the graft from the artery.
And Dr. White, when you talk about angles, are we talking 30 degrees, 45 degrees? What would you say?
I tend to cut angles so that they're about 30 degrees. The closer to flush that you can get with the vessel. Now, with the synthetic grafts, the nearer the angle you cut, the longer the hood is. So you have to be prepared to expose more artery. Take care of a greater length of artery as well. But 30 degrees usually puts you at a reasonable location. And they really are an excellent addition to cannulation.
And Dr. White, what material do you like to use?
I'm sorry?
What material do you like to use?
I do tend to use externally supported PTFE just because it's externally supported and more resistant to kinking.
And so it won't collapse down on itself.
Yep.
Okay.
I might add just 2 quick comments to the concept of the chimney, which we use for access, especially in the axillary and subclavian space for other adult-related vascular procedures. PTFE is beneficial because, in theory, it's also going to offer a lower risk of infection. But I do think that's something to keep in mind. If you cut your graft flush, because extracting all of the prosthetic would necessitate a patch for sure. You can do that with a vascular load of a stapler, which is probably safest. But you are leaving a cuff of prosthetic behind that does have the potential over time to become infected. And certainly there's a risk of that if the ECMO cannulation is lengthy.
And I imagine specifically also if you're in adults, obese adults, you're in the groin compared to some of our neonates in the neck. Okay. Thank you for that input. Another interesting technique that was introduced around the same era was the subclavian or axillary artery cannulation. This technique was demonstrated with both direct cannulation and with chimney grafts. I've personally only used them with chimney grafts, but I understand that both ways can be done. The technique was introduced as a way to gain non-carotid large vessel peripheral access in adults via cut down onto the axillary artery as it passes through the deltoaprectal groove. Initially, this was met with great enthusiasm. I remember when I was in training and it was the whole hype when it first came out, as it allowed patients to be on peripheral VA ECMO and avoid the morbidity of a femoral cannula. I was watching patients that were working with PT, walking across the bridge, getting out of bed with these, but the popularity has waned since that time due to significant issues with limb hyperperfusion syndrome, characterized by edema and severe pain, as well as some bleeding complications along the way. At the time of decannulation from ECMO, with the vessel ligation technique, there are two main approaches to the carotid artery. The first is to remove the cephalad suture ligation, restore patency, and close the arteriotomy. The second is to simply ligate the vessel at the time of cannula removal. And this remains quite a debate as to the utility and the risks associated with restoration of flow, especially after long runs. This brings us to our next audience poll. For those of you in the audience who perform vessel ligation for cervical VA ECMO, do you reconstruct the vessel? Seems like almost everyone here does vessel ligation. So all of those who routinely reconstruct the vessel, raise your hand. Okay, a couple hands in the audience. And if you routinely ligate the vessel, raise your hand. So it seems like almost everyone in the audience. Does anyone here do anything different? There is a depends. Yeah. So does age matter in your decision making? Age, length of the run, I just heard. Quality of the vessel, for sure. Absolutely. And some of them, you know, when you keep those kids on for months and months and months, you go back and the vessels, you know. Diagnosis, definitely. Yep. I think, you know, it's interesting. There was a study that came out looking at those cardiac patients, looking at the number of patients who actually require a second run. And ultimately, the number of patients that require a second run is less than 10%. It's actually closer, I think it was like 4 or 5%. But the single ventricle kids are the ones who we should really be thinking about. I don't know how many people here take care of our cardiac patients in addition to our respiratory runs, but those single ventricle kids have a much, much higher rate of needing a second ECMO run compared to the rest of the cardiac kids. Anything from our expert panel?
I think most of it was mentioned, and for me, the last thing would be, if you're going to reconstruct a carotid, you want to make sure that there's no residual clot left behind that's going to embolize. So the vessel has to be big enough to permit some sort of thrombectomy.
Just from our Seattle experience, we look back, there's been lots of, as people in the audience know, lots of studies about, you know, what happens to those arteries after reconstruction. And when we look back at hundreds of reconstructed arteries in a 20-year experience with us, didn't matter who was doing it, whether it's cardiac or us. Obviously, cardiac surgeons were doing a lot more of it. Didn't matter running or interrupted. It didn't matter length of run. What really, the only thing that came out was age of patients. So the neonatal population had a multifold higher rate of stenosis or occlusion. So it's not surprising, but just something to consider.
Yeah, I think that makes sense given what we know about our adult vessels and how we treat our adult vessels, the distal vessels versus the proximal vessels. Absolutely.
For the venous cannulation, some people feel like there's more value in reconstructing the vein. Does the panel, the audience have any feelings about that?
So I can start off by commenting on that. I do all of my VVs as much as Yeah, the question was for VV ECMO, is there value in reconstructing the vessels? I think the difference is some people do open cannulations and some people do perc cannulations. For most of mine are perc cannulations. What I found is that I pull and hold. And when you look at the studies that look at the ultrasound a year out, 2 years out, and there's one study that looks almost 4 years out on those vessels, they're all patent. The patency rate is over 90%. So even with the large 27 French, VV cannula that you're putting in, a pull and hold seems to work pretty well.
Yeah, I totally agree with that approach. Rarely do they need to be formally reconstructed. I will just say I'm of the opinion that if you don't need to ligate something, you shouldn't. And certainly there's less challenge probably in ligating a jugular than there is a femoral vein, but we harvest deep veins with frequency and we don't always reconstruct for trauma. So it's probably fine, but if you don't have to, probably shouldn't.
Did that answer your question? Okay. Sure.
Question for our vascular surgeons. I just had a debate with our PICU docs today about a kid who's been on ECMO for about a month. So sorry, it's a scenario, kid's on ECMO, VA through the neck. He's 3 years old, just coming off. He's going to have to stay on hemodialysis. And so we're going to decannulate and have to put a dialysis catheter into the jugular vein. The question is, do we reconstruct the carotid artery or not? Are you worried with having a reconstructed carotid artery right next to a jugular that contains a giant hemodialysis catheter for potential complication with your carotid repair? So that's
How are you going to repair the carotid? I
a
think that matters a little bit.
simple interrupted, maybe a patch on top of it.
Yeah.
Right. The studies that we look at show no difference in short or long-term outcomes with repair, but we don't know what they're like when they're 60 years old, 70 years old. There's some evidence of thickening of the opposite side carotid in kids who just have one carotid.
That's probably low, but that's where your reconstruction technique matters. And so if you patch the carotid with bovine pericardium, I think that's a valid risk if you're going to have consistent indwelling catheters. So I think if you can reconstruct it with a primary set of sutures, great, do that. I think the bigger question, and it probably gets to what you want to talk about, is what's the long-term prognosis of a child who's going to have end-stage renal disease, who may or may not get transplanted at some point, but whom we know is going to have accelerated cardiovascular disease. We know that for all comers, cardiovascular disease is striking teenagers and young adults in a younger and younger and younger age. And we see that already manifest with peripheral vascular disease to the legs and tissue loss and early amputations. We also see that reflected with intimal hyperplasia in the carotid, and in theory, an earlier age of onset of carotid occlusive disease. So really, some of what you're contemplating has impact if these children become 50 or 60 and you're worried about carotid occlusive disease. And I can't imagine that that's really on anybody's radar when you're trying to bail them out of this hemodynamic situation of sheer collapse. But I would say if you're going to have a cannula, I definitely wouldn't put a prosthetic or a bovine pericardial patch there. I think that's probably high risk.
And for those in the audience who didn't hear what Dr. Gray and Dr. Fisher was saying, the neurocognitive outcomes, which we will go into in just a minute, the long-term neurocognitive outcomes that we have so far are essentially the same. So that's what they were just saying. So let's go a little bit into that. So this is a study by Dr. Linden, Ali Linden, on the behalf of the Children's Hospital Neonatal Consortium, published in JPS in 2013. A survey was distributed to the 37 institutions within the network, and the respondents reported their standard approach to carotid artery and IJ. The response rate to the survey was 95% and showed that nearly 90% of all respiratory ECMO cannulations and decannulations were performed by us, pediatric surgeons. The remainder were done by cardiac surgeons, and of the pediatric surgeons, nearly 90% of them routinely ligated the vessels, which is, I think, what we're seeing across the board in this room. Meanwhile, CT surgeons overwhelmingly reconstruct the vessels to a tune of 83%. Common reasons that pediatric surgeons ligate the vessels include long-term vessel patency, which was brought up, concern for reperfusion injury, concern for antegrade embolic stroke, but the biggest reason was actually unestablished practice. How many people in this room were trained to reconstruct vessels? So the old mantra of this is how I was trained, right, holds strong. And just like every great debate in surgery, there are papers that both support reconstruction and data that supports ligation. I had to search a little bit for this, but this is a paper from the Journal of Pediatrics out of Jefferson, looking at a cohort of 34 patients with reconstruction versus 35 historical matched cohorts. In this study, they found that reconstructed patients had less brain abnormalities on cross-sectional imaging at hospital discharge, a trend towards less cerebral palsy, and 74% had luminal patency at 4 years follow-up. Now, as ECMO is a rapidly changing field, as all of you know, both in terms of management, cannulation techniques, cannulas that we have, all the equipment that we have, I think it's really difficult to interpret data that used historical controls, but it's good to note that there is support for reconstruction. Meanwhile, here's a paper from JPS out of Vanderbilt. This was a retrospective study of all neonates with congenital heart disease who had VA ECMO between 1989 and 2012. 140 neonates were placed on VA ECMO, and of the 84 survivors, 51 had carotid repair. The vessel patency in the study was 84%, so it was also equally high. And interestingly, there was no demonstrated difference in brain abnormalities on cross-sectional imaging. There are several more smaller studies that I didn't include here that I've looked into the question, all of which have not demonstrated any difference in long-term neurologic outcome. There are 3 studies using PCPC scores. There's 2 studies using Bailey scores, and all 5 of these did not demonstrate a difference. And like these 2 studies, I think everything thus far has either been retrospective or a small n number. And so my conclusion from this was we need some good prospective studies to fully answer this question, maybe to the younger generation here in the audience. And I'm curious to see if our expert panel has any other thoughts or ideas on this topic.
I might rephrase the question as not so much should we or should we not reconstruct this. Once you reconstruct, if you choose to reconstruct, what should you do subsequently? We have unanswered questions about anticoagulation, about timing of anticoagulation types. We have unanswered questions about how long you should image for and what do you do with that imaging. Should we get MRAs? So we've talked a lot amongst ourselves. I think there's a lot of data emerging to support long-term monitoring and then pairing with our adult vascular colleagues to say both what Dr. Coleman mentioned, intimal thickening over time and also carotid occlusive disease. And then even more interesting would be like, are there genetic predispositions, whether it's cholesterol levels or other stuff that I don't even know about, prothrombotic maybe states where you should be judged at even higher risk to have more intensive monitoring. Just a pitch for more data.
I'm going to pitch 2 other comments. The first is that I've seen adult patients come to my clinic, my adult clinic, with carotid artery stenosis. And an ultrasound suggests elevated velocities, and that triggers cross-sectional imaging. And I've found really hypoplastic or diminutive carotid artery. And it turns out in both cases, these young women have a history of prior ECMO cannulation. And so it is possible that your ligatures can recanalize. And it probably is physiologically irrelevant. But again, it gets to the consideration of how many decades of life these patients are intended to have. The other thing I'll say, and I don't know that John will agree with me, but I'm going to throw it out as a wild concept. You referenced that the majority of people who responded to the survey may not have been trained to manage these vessels, to repair them. We realize across both of our specialties, this is a very real gap. So what a great opportunity to have people maybe getting a little bit more comfortable with vascular manipulation.
For
I
sure.
think it's super interesting. I wasn't aware of the differential patterns of practice between cardiac and pediatric surgeons.
For sure.
Yeah, I would agree with that, and I would say that for repair, you have to be a little bit careful about how you repair. If you can repair it transversely, so the rule of thumb for an artery is if the cannulation injury represents 1/3 or less of the vessel circumference, then you might be able to repair it directly with interrupted sutures. anything larger involving a larger amount of the circumference tends to buckle the back wall of the vessel. So that there becomes turbulent flow, and that's a setup for stenosis. So if you can repair it with interrupted sutures transversely, and there's less than 1/3 of the circumference that's injured, it's reasonable to do so. The challenge you get to is if you have to convert to a longitudinal arteriotomy, then you can't really repair that directly.
So a lot of these vessels are pretty much cracked. Every time you take the cannulas out, you're like, what are you sewing? It's like sewing a pattern. You just have no structure, no spring.
I mean, yes, with the, even the Rommel tourniquets or with the ligation, the vessel can be injured, severely injured. Probably the majority of the strength of any repair lies in the adventitia. So that if your adventitia is destroyed, if that outer layer is destroyed, you're right, repairing it is not going to gain very much. That's going to fall apart in the future. So it's the outer layer of that blood vessel that's going to be crucial to the integrity of your repair.
I think the size and the age probably matters here as well, and that hasn't been teased out of any of this data. But I personally would have a really hard time ligating the carotid in a teenager, for example. And I can think of some shared cases with our pediatric surgeons at Michigan, at Mott Children's, where we would do these repairs together on occasion. Yeah, yeah.
I'm just going to repeat what he said. The question was, isn't the vessel mostly crap by the time you decannulate? Yeah.
Tissue paper.
And I think everyone knows what he means by that. Okay, so any last comments on carotids that got lively? We're going to move on to femoral cannulation. Okay, so now we're going to move on to femoral cannulation, again focusing on arterial access for this session. So here's a poll. Who's cannulating 2-year-olds in the groin? Okay, what about 8-year-olds? Okay, got a couple. How about 13 and up, teenagers? Okay, all right. Expert panel, we have some consensus there. I guess Dr. Rothstein mostly on that one, the 2-year-old.
No, I think because they're weight-based, a lot of people take 20 kilos. I think it's probably small
Yeah.
for me, but that's the number that gets thrown out.
Okay, all right. So let's talk about percutaneous versus open cannulation. Oh, I thought I had a poll. I guess I don't. Or was it? Oh, I guess that was also supposed to be a perc versus open cannulation. So for your 13-year-olds, is everybody doing those percutaneous or open? Who does percutaneous? Okay, open. And it depends on the situation and the patient's body habitus and the emergency nature of the situation. Okay. All right, so here's a retrospective kind of ELSO registry study looking at 3,500 pediatric patients, and still the majority of people are cannulating open. However, this includes all cannulation sites, but 77% were open and only 22% percutaneous. Open cannulations were more likely to, again, be in younger children and for VA ECMO, which we've kind of assessed out through these polls as well. It seems like we're all kind of in agreement there. And then older patients, 12 and up, more likely to be cannulated percutaneously. If a practitioner is going to do something percutaneous, it's going to be in an older patient, I guess is what I mean to say by that. Open cannulations tend to have more need for cannula site repair at the time of decannulation, which makes sense, and then a lot of times more bleeding at the cannulation site. However, percutaneous access can have more limb complications or limb ischemia complications. Over time, percutaneous access is slowly increasing, kind of stabilizing at this point, but over many years, it's been slowly trending up. For VA ECMO, percutaneous cannulations are trending down, and for VV ECMO, they are trending up, which is in line with my practice, and I think we would mostly agree on that. I'm going to move ahead since we're going to get to some more discussion points. So this is a The chimney technique, I think, is really interesting to talk about in carotids. Maybe not used as much because a lot of times we're doing it in babies. But in a larger patient, especially in kind of a semi-elective cannulation, this is a really interesting and can be useful technique to, number one, preserve limb perfusion by being able to put the cannula into the graft and not all the way into the vessel, and therefore not causing some flow stenosis or flow limiting stenosis down the leg. And then the other thing is that when you tunnel this graft, you have a whole leg to tunnel on. So getting it out of the groin is a really big benefit, especially in really large patients. So a picture like this, which is from this really great paper for reference about pediatric femoral arterial cannulation, demonstrates this technique where you sew the graft in, tunnel it down the leg, close the groin, and then you don't have this foreign body open wound situation that you would deal with if you had it coming straight out of the groin. We've already talked a little bit about the chimney technique. Do you guys have any? Dr. Coleman or Dr. White, have any comments on the femoral on this for the femoral cannulations?
No, I think chimney there can be a benefit if you don't if you leave the cannula in the chimney and you don't try to insert it all the way through the anastomosis and into the vessel, you don't need a distal perfusion cannula because you will have prograde flow down the leg and you will have your cannula in place, which is one nice advantage.
Yeah.
And closing it, keeping everything sterile because we talked about the risks of infection of the prosthetic. So those were all good solid techniques.
And then at the time of decannulation, you don't necessarily have to get all the way back to the artery, or how would you decannulate this patient?
I tend to leave the stub of the graft and close it as a patch.
Yeah.
But again, you can only do that if you're convinced that there's no evidence of infection.
Yeah. Oh.
Oh, I would 100% take the whole thing out and patch the vessel with vein. I worry about groin infections.
About infections,
They're super
yeah.
ugly, personally.
So the cardiac surgery group at Sick Kids does this on almost all their bigger patients, and I had a discussion with them about that. They made a really good point, is that when you're at high flow, and if you're flowing in there, just as we say, you don't need a distal perfusion catheter, but that whole flow is also going down the leg.
Yeah.
So they get overflow down the leg. So they've actually had to put clamps or put the little pot screws around the SFA going down the leg so that they don't put it.
Like hyperperfusion is a risk, yeah. Yeah, like they're PA banding the leg.
Is the venous element of this on the same side then in general?
Oh, we're gonna get there. There's a pole, there's a
Sorry.
pole. We're gonna get there.
Okay, well, I guess, it would lead to congestive venous return, which would really increase your risk.
One of the ways to mitigate that imbalance is exactly what Dr. White said, but yet also drives your flow in the right direction. You put the tip of the cannula through there, right? But to not drive in and include the artery, you can still balance it. Now, that's a tricky balance, right? A day or two later, you may be left in a situation where you're not getting this perfusion, either you're not getting forward flow. But that's one way to potentially mitigate that situation if you want to change it, or put it, including something distally.
In Chuck Fraser's drawing, he's got this really long graph.
Right.
And I think it's really important that if you don't stick it in very long, your graph will eat like crazy. And so I don't, like, and I don't know if you guys have had that experience, that was just me, but you do have to stick it in far enough that you don't have the entire graph eaten.
Has to have a big enough and long enough cannula too, so bigger kid. Okay. All right, so here's the next poll. So who's putting the femoral, oops, oh my gosh, okay. Who's, now no one's gonna vote for the other one. Who puts their arterial and venous cannulas on the same groin, preferentially? Okay, who does the opposite groin? What do you think about that, Dr. Coleman?
Oh, I think I hinted at it, so it makes such good sense to me.
To do the opposite?
To do opposite.
Yeah. We think, there's a couple benefits to doing the opposite groin. One is that you reduce the venous congestion in a limb that may be compromised by having this large cannula in it, depending on how you cannulate, but there's some degree of arterial compromise to the leg on that side a lot of times. And then the other thing is that if you have two teams, which a lot of times there's a lot of people around when this is happening, or sometimes there's nobody around, in which case it doesn't matter. But if you have two teams there, you can each do one side and you get on ECMO a little bit faster, especially in a big kid or a heavy child. Anyone have any comments on that? This is interactive. No? Okay. Depends on the. Just do both. Yeah. 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 Someone can do one side. Important notes about percutaneous arterial access. I think we all know this, but it's important to make sure that you're sticking the common femoral artery, not the SFA, and not too high. Don't want to have a retroperitoneal hemorrhage by getting into the iliac, and the SFA, if you occlude the SFA, the cannula will be completely occlusive and cause limb ischemia. One of the other things to remember is that a lot of times you get tempted by the arterial line that the PICU placed into the vessel, and it's usually not at a 45-degree angle. It may not be in the common femoral artery. No one really knows where it is. So it's just be very careful before you just stick a wire down the thing and dilate it up to 21 French. It's a lot easier to take out a 20-gauge catheter and then start over again than to deal with an angle that's wrong or something like that when you have a big cannula in. Yes?
I have
Matthew.
a
Yes, you are.
Well, I wonder if, to your point about not knowing where the A line is or the arteriotomy, how often would this team be using fluoroscopic guidance for any or all of this, either with a C-arm or even getting back to what we talked about this morning, a hybrid room?
Yeah. You want to answer that? Yeah.
Scenario. A lot of times this is ECPR, quasi ECPR, and trying to get to a fluoro-capable unit is not able to get to. At least for us, we don't also have fluoro-capable beds in the PICU.
We have. Yeah, I think what he said is it depends on the scenario, and I think that's true for everyone. I mean, we do have the capability of getting fluoro beds in the PICU, but it takes a little time. It's not an ECPR situation. So if there's time, then we love to have fluoro. Everyone, I think, loves to have more imaging than less imaging, but it just depends on the situation. Okay. Now let's talk about reinfusion catheters. So if you don't do this chimney graft, if you're just placing a femoral artery cannula in a percutaneous manner, we try to do some reinfusion to the leg as well. There's two options. One is a retrograde at the ankle at the DP, but because we're talking about arterial reconstruction, we are going to only talk about antegrade SFA reinfusion catheters. And so this is a technique that I think is very helpful to place these cannulas. So it's very challenging to get antegrade access into the SFA once there's already a flow limiting cannula in the common femoral artery and there's barely any flow trickling through it. So one of the, you have your wits about you. This is not necessarily an ECPR situation. You're very cool, calm, and collected in this situation. And ultrasound the groin, get antegrade access into the SFA with a micropuncture wire, micropuncture needle and wire, and then leave the wire in there while you cannulate the common femoral artery. And then once you're on ECMO, you can then dilate up and put your 6 or 8 French reinfusion catheter and wire it into your circuit as pictured here. So that's the ultrasound kind of picture that you can imagine, putting the wire in there, leaving it, getting access, and then putting your cannula in afterwards. We would like comments on that as well.
I think that's probably the only way to do it, because as you said, when there's no flow in the SFA, trying to stick it just, it's almost blind, even if you're using ultrasound.
Yeah.
So that, yes, you definitely want to do it before you place your major arterial cannula.
And then if you are in a situation where you place that arterial cannula first, you want to go back? Yeah. He said that that's a great picture And it shows the two the two access points really close to each other, which means they're going to be in the same incision for the reconstruction. You said to repeat the questions. I'm repeating. Okay. But if you don't, I mean, if you get on ECMO and you didn't place a reinfusion cannula, you can, I mean, once you're on ECMO now, everything's fine. You can kind of cut down and do an antegrade open access to the SFA with a Ramel tourniquet, or and then just secure everything in place in the same way. And a lot of people, that's people's preferred option. So it's not, you don't have to be, you don't have to be really comfortable with that thing I just showed you, but you can do it this way too, just as good. Okay. And so now we're going to talk about decannulation. So we've already talked about the purse string. That's great. If you have a vessel sparing purse string on a Ramel tourniquet, a lot of times it can be tied down. We talked about chimney grafts as well. So now let's talk about patch versus not patch, since we're almost out of time. So how does everyone decide whether or not to patch? These are the factors that kind of come to mind for me: size of the cannula and size of the arteriotomy in relation to the vessel, which Dr. White mentioned, 1/3 of the diameter; length of the ECMO run, which is kind of a surrogate for the rattiness or the crappiness of the tissue; integrity of the vessel; and then what other considerations would come to mind when you're thinking about looking at a vessel that you just took a huge cannula out of, and how to decide whether to patch or not, risking, the risk of infection versus the risk of stenosis.
For me, again, it depends on, how you can close the arteriotomy. If you have a longitudinal arteriotomy, your only two options are to resect that portion of the vessel and do a complete end-to-end anastomosis, or, you use interrupted sutures if it's less than 1/3. Once you have a longitudinal arteriotomy, which may be required because of damage done by the cannula. So, if there's evidence of a dissection of the intima extending up, you might need a longer arteriotomy, a longitudinal arteriotomy. And I believe in patching with autogenous material,
Okay.
I'll use vein.
Yeah. Okay. How do you assess the intima besides looking into the vessel when you open it? Is there any other things that you would do?
Well, I think it's twofold. One, I think you need to be able to get some bird's eye view through your hole, and you generally can see if there's shiny intima or not. If you can't appreciate, meaningful retrograde and antegrade flow, or you have any concerns about focal dissection or webbing or intimal trauma, I have a low threshold to repair those more formally, or at least make a longitudinal incision on the vessel to expose it and then patch it. The other thing you can do is close it primarily and then do an on-table ultrasound, because then if it looks irregular or you see mobile flaps or something's not quite right with your completion study or your signals by Doppler, you've not lost anything. You can then go back and fix it while you're there. And I would definitely use autogenous superficial great saphenous vein for a patch.
This is a picture from that same paper with using the same side great saphenous vein. It's right there, and if you have done your venous cannulation on the other side, then it's untouched. And so I thought that was a really nice.
I
Sure.
would just be cautious in using ipsilateral GSV if you've cannulated the deep
The
vein on
vein.
that side, because I think the same principles for vascular trauma apply in this scenario, albeit iatrogenic.
You don't want to compromise both of the same leg.
Yeah, probably not.
We have some things about percutaneous closure. I don't know. We're almost run out of time. Do you guys have are people doing this in the adult world after ECMO? Okay. Is anyone doing it on PD? You guys doing percutaneous closures? So this one is a suture-based closure. It's after the fact. It can be placed on a wire into something up to 8 French and close it. If you want to do something a lot bigger than that, it has to be kind of pre-deployed, is how I understand it. You have to do you place a couple sutures before you cannulate, leave them. It's like the minimally invasive version of a Ramel tourniquet. You have those sutures in place before you place the cannula. And then there's these other ones. This one's for bigger holes. It kind of places a patch on the outside of the vessel with a little anchor on the inside, so it doesn't have the flow limiting risk of kind of placing those blind sutures in a bigger cannula hole or cannular arteriotomy.
The ProGlide device is excellent, and it's actually not blind, so that really should be deployed with fluoroscopic guidance.
Okay.
And I've used it on arterial and venous areas of defect for adults, not just for routine access and endovascular aneurysm cases, but for cannulations for left heart bypass for open thoracoabdominal work.
Okay.
And you theoretically can use them as a post-closure device if you angle them. You don't have to use a pre-close technique. The pre-close technique is just a little bit more controlled. You're going to just have to be a little bit more aggressive with your manual pressure if you're trying to deploy them after the fact. And whether it's one anterior or two oblique deployments, I think that's fabulous. I can't comment on the other ones, and I get a little bit nervous when you see kind of plugs and material attached to it, because those can go through your holes, to be very honest, and we see those mal-deployed, and there's a constellation of catheterization-related challenges that we manage in adults from, mal-deployed closure devices. But this ProGlide technique with simply prolene suture is really quite excellent.
Something to keep in mind for it's something that our vascular colleagues can help us with if you guys are in a situation where you might want to do that. Do you have a question?
No, so we actually use them fairly, on a regular basis here, is we use them for our adult patients, for ECMO closures and selectively. And we use a couple of pediatric patients, however, the pediatric patients that we've used them on have both been for palliative decannulations that we've just palliatively decannulated to get everything out of the way for them to pass with their families, and they've been very successful for that. I don't know that anytime we've decannulated, we haven't used this without.
You may want to take some caution in using them for super long runs, just if you
'Cause
have
of the
concern about
vessel
vessel integrity.
integrity.
This could make it worse. So it probably
Makes
should
sense,
be
yeah.
considered limited for your shorter runs.
All right, well, we are done because of the time, because it was such a lively discussion, because this was so much fun. One more comment? I'm going to leave this up here.
Hoping you guys would, hey Don, I was hoping you guys would help us, how do you decide between an older kid that needs to go in VA ECMO, going in neck versus the groin? We didn't really talk about, how to choose which approach.
I think for most people, it's based on age. In small babies that we're going in the neck still, and then around 12-ish, everyone has their own personal threshold, but then they switch to the groin.
Anybody cannulating in the neck and, like young teenagers?
So
I measure the vessels. The question was, how do you decide whether to go neck or femoral on those kids who are borderline? I think it's important to measure out the vessels. So get a good ultrasound study of your vessels. You know what flow you need because you can calculate that out. You know what size cannulas go with that flow. And then you can really titrate it to the patient, because sometimes I've found some bigger kids with very small vessels and then vice versa. Should we go over this just?
I think we can just leave it up here. I think it's important. One of the important things is that we don't do a good job of surveilling these patients. And after they've been instrumented with ECMO, there's a lot of stuff in the Red Book about how to follow them neurodevelopmentally, but there's not anything about what to do with their vessels and how to follow them. And so Dr. Rothstein is very passionate about this, but maybe you can catch him over drinks later to talk about it.
There's a difference between passion and expertise. I'm in the passion group, no expertise.
Thank you.
All right, thank you.